All right. Well, thanks again for the invitation. My topic today is CAR T therapy in diffuse large B-cell lymphoma. When do we use it? Which agent do we use? So I will walk through that with you. These are my disclosures. The other disclosure is that our stem cell transplant group here at the University of Virginia generally manages our CAR T administration. So I'm less of an expert than they might be in terms of the management through the initial CAR T transplant. But we're going to look at the data today for how we got CAR T cells available for this unmet need in relapsed refractory DLBCL. And then we'll talk about the more recent data comparing CAR T with auto transplant at essentially first relapse. So you're familiar with this, of course, in this transplant-oriented group. We collect T cells from eligible patients, expand those in the lab after they've been modified with the chimeric receptor that has a dual binding to CD19 on the tumor cells, and with the T cell link as well. We expand those and then reinfuse them into the patient. So I'll start with just a quick illustrative case from our own center. This was a 62-year-old man who was primarily refractory to his initial rituximab CHOP regimen. He was sent to us. T cells were collected. He had brief bridging therapy. We produced the CAR and infused them. And that was back in 2019. He was one of our earlier patients. You can see he had very extensive sites of disease following his induction chemo. And then here he is 60 days after completion of the CAR T with all the lymphoma sites in remission. And he remains in remission since 2019. Those of you who are noticing that there's an abnormality here at the bladder, it turned out that this persistent site was investigated and found to be a localized bladder cancer, which was subsequently managed as well. So CAR Ts were curative for this gentleman. So there are 3 CAR Ts approved in the US for diffuse large cell, and these are tisagenlecleucel or Tisa-cel, axicabtagene, ciloleucel, axicel, and lysocabtagene, which is Lysocel. You can see they all target CD19. Tisa-cel is also approved in younger patients with relapsed B-cell ALL, and axicel is approved in follicular lymphoma. They have different signaling molecules. Axicel uses CD28, whereas the other 2 use 4-1BB. That has potentially some relevance in terms of rapidity of T cell expansion in vivo after infusion, 10 to 12 days for axicel versus 3 to 4 weeks for the other 2. And there are also some potential relevance. There is potential relevance related to toxicity. So these were the pivotal trials that led to the FDA approval in relapse refractory. So these were patients who had had at least 2 lines of prior chemotherapy. They were given in these studies with curative intent. So they did not get CARs and then an auto. These were CAR alone. You can see about 90 to 100 patients. Here's the overall response rates, which differed in part perhaps due to patient selection in these different studies, but you can see about 60 to 80% got a response and about 40 to 60% a complete remission. Here's the 3-month response rate. And you can see the duration of response was about 9 to 11 months, not reached at this point for the Tisa-cel study. Cytokine release syndrome, which I'll go over in a moment, also differed, and here may be the difference with a CD28 or 4-1BB in CRS as well as CNS toxicity. So when you're selecting patients for CAR T, I'll just call your attention to this very recent review in Nature Reviews. We're looking at patients who have active progression during initial therapy or a salvage regimen or following prior treatment. Performance status 0 to 2, no severe organ dysfunction, active infections. Heavily pretreated patients may respond well, although you may have more difficulty collecting sufficient T cells in patients with extensive prior therapy. You can see responses even with secondary CNS, parenchymal, or leptomeningeal involvement. Does not appear that a CAR administered to patients with CNS disease necessarily increases neurotoxicity, but it is known, as in the final bullet point here, that if you have a high disease burden going into the CAR, they do not do as well, probably because there's just less of the cellular immunotherapy effect, but also those patients tend to have more cytokine release syndrome and neurotoxicity. So what about the use of bridging therapy? That differed among the regimens. So one of the challenges with this procedure is that these patients with relapse refractory disease often have higher volume of disease and they progress rapidly, so that it can be difficult to bridge patients and control their disease sufficiently to allow the weeks that are required to get the patient in, get them evaluated, collect the cells, produce the CARs, and then get them administered. So what are the bridging therapy options? Well, you can use a typical salvage or second-line regimen, such as rituximab ice. In general, it's much preferred to try to collect their T cells prior to chemotherapy. If the lymphoma happens to express CD30, you can use brentuximab vedotin. We most commonly use polatuzumab rituximab for our bridging. We try to avoid bendamustine, certainly before their apheresis. Bendamustine will impair T cell collection. There's newer data that was presented at ASH and ASCO in the past year. I'm sure we'll hear more of this at the upcoming ASH meeting, using bispecific antibodies as bridge. These are anti-CD20s, so they avoid the use of an anti-CD19 bispecific. The radiation therapy data is intriguing. If a patient has a localized site of disease causing symptoms, or it's bulky disease, radiating these patients may in fact release antigens and promote an immune response with subsequent immunotherapy, including CARs. So that's an area that is discussed in this article by Amini and colleagues, but very intriguing. So there's an unknown impact right now if you use an anti-CD19 therapeutic and how these patients will respond. So theoretically, if you've given an anti-CD19 binding antibody, then the CAR CD19 receptor will not be able to bind. And so therefore you may impair the CAR response. There's limited data that you can still see responses in about 50%, but I think for the time being, if you have other options, which typically you do, then we try to avoid using those. And this is just a schematic for your reference, again, with relating to the anti-CD19 approaches. You can see here the different options that we have. So what about toxicities? This is a concern with this therapy. We use lymphodepletion, typically cyclophosphamide and fludarabine, prior to administering the CAR. That essentially, by lymphodepleting the patient, it makes it more a more amenable environment for the CAR expansion. And I already mentioned CRS and neurotoxicity. So CRS can have hypotension, fever, capillary leak. And the toxicities here, again, just by way of a schematic, there can be disruptions in the blood-brain barrier, endothelial activation that can lead to neurotoxicity, which can include sort of sedation, delirium. Aphasia is probably most common, leading and potentially even to seizures and cerebral edema. Hemodynamic instability. So when you the CARs bind there and you get this intense immune activation, then you release a number of inflammatory cytokines, including interleukin-6, which can lead to complications listed on the right. So in more detail about CRS, you can see that it's an inflammatory response, as mentioned, with a supraphysiologic release of the cytokines listed here. But IL-6 is the most important player in this, and therefore it's a target for managing these patients. So it's this occurs primarily via activation of lots of lymphocytes, as well as myeloid cells, including macrophages and dendritic cells that release the cytokine storm. There's a grading scale for this. You can see that grade 1 is fever without hypotension or hypoxia. Grade 2 is some degree of hypotension, but not requiring pressors, versus grade 3 and 4, where you do need vasopressors, and then varying degrees of hypoxia also give you a higher risk. So just to comment, I really managing the CAR T complications, including CRS and neurotox, is really outside the scope and time for this talk. But in general, if a patient has grade 2 CRS, we utilize dexamethasone or tocilizumab, the anti-IL-6 antibody, for 2 to 3 doses. Older patients, especially those over, say, 68, 70 years of age, even if they're having grade 1 with 3 or 4 days of fever, then our team and others will most often use a dose or 2 of toci in that setting as well. Now, what about neurotoxicity? So this is defined sort of generally, characterized by pathologic process with any immune therapy. So you can see this, as you know, with bispecific antibodies as well as CAR Ts. I mentioned already the spectrum of disease, including aphasia, which is the most common, varying degrees of encephalopathy, seizures, cerebral edema. The pathophysiology really isn't fully defined. We know there's disruption of the blood-brain barrier. You can get CAR Ts into the CSF. It can treat disease in those sites. So the interplay between the microenvironment and the neural tissues and this immune activation isn't completely clear. So all patients going on to a CAR therapy should have a baseline neuroconsult. We work closely with our neuro-oncology group. So any patient being considered for that has a formal consultation with our neuro group. They do testing as noted here. We also utilize, once the patient is admitted and the CARs are administered, once each shift, the nurses on our transplant unit go through this ICE scoring. And they document that in our electronic record with each shift. You can see how the point scores that are allowed here. And so then the grading for neurotoxicity is founded on the ICE score. So if you have just minimal, perhaps cognition changes, then you're a 7 to 9, but none of the other abnormalities listed here. And then it advances from grade 2 through grade 4, where patients have very advanced neuro complications. And this can be a fatal event. So given the variance, it's often a real challenge with these therapies. Generally, these are managed even with certainly grade 2, but grade 1s will sometimes observe for a time, but if it's persisting, we'll go ahead and use dexamethasone, which is preferred over, say, solumestrol or prednisone because it has better CNS penetration. So that's an overview of CARs. Let's look at the recent data comparing CAR to auto transplant in relapse refractory. So now second line, instead of after people have received a couple of other lines of therapy or after failing an auto. So to frame this, let's look, just as a reminder, this is actually the CORAL study was led by Dr. Moskowitz that you just heard from some years ago. So this looked at patients who had relapsed after initial treatment, whether primary refractory to it or a later relapse, and they were comparing rituximab plus DHAP versus Ritux ice, and then patients who responded, if you had a CR/PR, they went to a beam conditioning, and then a second randomization to either observation or maintenance rituximab for a year. Patients who had progressive or stable disease went off study. So this was a large randomized multinational study, and they had about 400 patients. About at the time of this study was started, that not everyone, especially in some of the other countries, had had rituximab. But what they found was that if you relapse within a year of completing initial therapy, especially if you had rituximab with your therapy, those patients did poorly. And there was really no difference for the two inductions. So either one that your center is used and comfortable using is appropriate. But you can see with prior rituximab exposure, only 20% event-free survival at 3 years. If you relapse within a year, especially, they did very poorly, and you can see that here graphically. So if you're chemosensitive and you were especially more than a year out, you did, over 40% of those patients appear to be cured, but a rapid fall off if you failed early. So this data informed the 3 trials that I'm going to describe, looking at CAR-T for patients with this poor risk. So right now, if you relapse, high-dose therapy and an auto are the standard of care. But if they relapse early, they do poorly. So this study was a phase 3 comparing these early, either primary refractory or early progression within 12 months of finishing your induction R-CHOP or whatever immunochemotherapy you got. Then it compared CAR versus high-dose therapy in an auto. And in this study with Axicell, the ZUMA-7 trial, they did not allow bridging chemotherapy. So you could get corticosteroids, but this picks potentially a population of a little less advanced disease. These, you're not going to have patients with very rapid high volume progression in this study. So that's important as we compare to this other 2 that I'll share with you. So they enrolled 359 patients. 3/4 of these were patients who were primary refractory to their initial therapy. So a very poor risk group. 180 were randomized to Axicell, and 170, 90% of them ended up getting infused. In the standard arm, only a third of patients responded sufficiently to their salvage chemotherapy that they were able to go on and get a stem cell. So you can see the 2-year event-free survival significantly favored the CAR. Overall response and CR rate much higher for CAR. Overall survival has not yet been reached for those who got the CAR therapy. And you can see the 2-year PFS is 40%. They did not have a crossover in this study. And you can see the rates of grade 3 to 4, CRS and neurotoxicity 6% and 21%. It's also worth noting that off trial, about 100 patients, so about a little over half the patients in the high-dose arm did go off study and underwent a commercial CAR-T administration. And at the top 2 curves here, you can see the event-free survival significantly favoring CAR-T with, it's unclear yet where this plateau is going to be. There have been a few relapses going out to 2.5 years. And here's the overall survival. So again, not significant difference, but remember, many of these patients in the standard arm went on to a CAR off trial. And in the lower left are the subgroups where the forest plot, favors the CAR. So here's the summary. It was superior in all these patient subsets. They did better, or there was a lower CR if they had a high tumor burden and were in the standard arm. Toxicities were what we would expect. Very importantly here is that the CARs were produced quite rapidly. So 13 days on average to having the CAR ready for infusion. And so for these early progressing primary refractory patients, especially those that only need bridging with a corticosteroid, they did quite well with the CAR, and I think that becomes the recommended approach for this subset of relapsing refractory patients. Now, here's a study that had a different outcome. This was also presented at ASH and also subsequently published in the New England Journal. So Tizacel, tisagenlecleucel, same design, high-dose therapy, that same cohort of early relapse, primary refractory, same randomization in a phase 3. They did allow bridging therapy prior to CAR, so this was probably a sicker, more advanced and rapidly progressing population, and they allowed a crossover to Tizacel if they had an event at week 12 or later in the standard of care arm. Very different from the outcome with the other patients I showed you is that there was no difference in outcome for the two arms of the study. Virtually all patients got bridging therapy, but importantly, you can see the median time to getting their CAR infusion was 50 days after their leukapheresis. And a quarter of patients progressed before they got their CAR. They were still allowed to get it, even though they were having a progressing and higher burden of disease. Again, similar to the other trial, in the high-dose therapy arm, only a third of patients actually made it to a transplant, meaning that most did not get a sufficient response to their second-line chemoimmunotherapy. So the summary here, you can see there was lower grade 3 and 4 CRS and neurotox felt to be related to the potentially the 4-1BB versus the CD28 signaling molecule. So it was not superior in this trial compared to high-dose therapy. So the comparison, I think the take-homes from this is sort of the post-ASH and sentiment, and this was reflected in an editorial that accompanied the New England Journal papers, is that patient selection is important. It's also, I'll emphasize again later, that these results don't apply to patients who have a late relapse. Let's say you get a good response to rituximab CHOP, and 2 years later you have a recurrence of your DLBCL. The standard of care there is still an auto transplant if they're chemosensitive to second-line therapy. Not chemosensitive, then I would go to a CAR. If you're able to get patients to the CAR without bridging chemo, then I think Axi-cel would be preferred. It's hard to compare these two studies because of the differences in patient population. I think the rapidity of CAR T is important. You know, having to wait several weeks instead of 2 weeks to get your CAR therapy is a concern. Now, here's a study that was published more recently. This is looking at the third CAR, so Liza-cel. Again, patients with DLBCL relapsed to primary therapy early, 1-to-1 randomization. They allowed bridging therapy, and you can see the population here, about a third, 40% over 65 years of age, 73% with primary refractory disease. And here's the outcome. This was, again, a positive study. So the CAR T had an improved outcome over standard of care. And again, you can see the rapid progression in people who are largely chemo refractory, so that the 12-month EFS varied, was about 45% in the CAR T arm versus 23%, higher CR rate. And the 12-month overall survival also favored the CAR T therapy. These patients did, this study did also allow crossover to Liza-cel, and so that also helped rescue some of those. But you can see even in that setting, you tend to lose some ground without going directly to the CAR. Here's the CRS. You can see grade 3 and 4, again, was quite low in this study. CRS only 1 grade 3 event, and there were 4 grade 4 neurotoxic events. So less of these complications with this 4-1BB CAR. So here's a comparison across the studies for second line with their numbers. I won't read through these again since we've already talked about them. But importantly, these early progressing patients, only a minority of them get enough of a response that they can go on to a standard auto transplant after that early progression. So conclusions. So Axicell and Lysocell showed survival benefit over salvage chemo and an auto transplant for these patients with primary refractory or early progression. You didn't see that with Tezacell, and as I pointed out, these may have been sicker patients. There was also a longer time to get their cells. There's, maybe a more favorable population in the ZUMA-7 study for the reasons mentioned. So right now, I think for most of our patients at our center and others is that in patients with early progression, within a year of finishing their induction therapy or primary refractory, we take them to a CAR rather than an auto. I mentioned already about later relapsing patients. So with that, I will thank you again for the invitation. I'll be glad to take any questions.